Thank you very much, Natella. It's a pleasure to participate at this debate on a very important topic, DTG transition. A switch to DTG must be accompanied by change in NRTI backbone in children with confirmed or suspected treatment failure. And I want to say a big no. The lady in my slide there is not the first lady of Canada. She's my opponent. And she has friends in this audience who have already voted during the first voting exercise towards changing an NRTI backbone. But my goal is that by the end of this presentation, all of us should be weighing towards not changing the NRTI backbone. Let's start with the WHO guidelines. We know that WHO recommends that we should not change. We do not require viral load testing prior to optimization to DTG. And to me, this is a silent pointer to tell us about the confidence of WHO in dolutegravir, even with underlying resistance. And I'll be explaining this a little bit more on the next slide. So to me, this is a silent pointer that maintaining an NRTI backbone, as long as the child or adolescent is taking dolutegravir, the patient will still do well with or without underlying HIV drug resistance. Let's also unpack this question. The first part of the question is obvious, DTG transition. We know that if a child is stable, they are taking their treatments, they are virally suppressed, there's no reason for us to change the NRTI backbone. And the debate, as Natella has already mentioned, is focusing on those that are failing on treatment with suspected or confirmed failure. And we know that the World Health Organization, again, recommends dolutegravir as second-line therapy in patients in whom a non-DTG containing first-line regimen is failing. And we can see this on this slide. You can see in the red box that if a child starts with ABC3TC in their first line, the World Health Organization recommends that we should give them AZT3TC in their second line. And if they started on AZT3TC, they should get ABC. And we know that majority of our patients now are receiving ABC3TC NRTI backbone. But the big question is, do we need to continue doing this even in the era of DTG? And I would want to say a big, big no. When we look at the Nadia study, and we know that in the Nadia study, there were different arms. They wanted to compare patients who get dolutegravir as their anchor regimen and those that get darunavir, ritonavir as the anchor regimen, and they found out that both anchor regimens did very well. And they also compared patients where they maintained the TDF 3TC while patients were failing from first to second line. And in the other group, they gave patients AZT3TC in their second line. And we know from this study that dolutegravir in combination with NRTIs was effective in treating patients, even those with extensive NRTI resistance, in whom there was no NRTI predicted activity. I know my opponent will be quick to jump in here and say, but there was a very low representation of children. Yes, we can see that on the slide, but the results of the Nadia trial can be applied to children, even if we need, even while we still need more data and analysis for children. So do we need, with the Nadia study, the findings of the Nadia study, do we still need to move children from ABC3TC to AZT3TC? I would say no. Maintaining TDF in the Nadia study, they found was superior to switching patients to AZT in terms of achieving viral load suppression. And there were also additional benefits. For patients who stayed on TDF, they had reduced a chance of viral rebound, their CD4 cell count did well, and there was reduced risk of high-level dolutegravir resistance. So if you when you look closely at these results, you can even say that maybe AZT is not so good in preventing high-level dolutegravir resistance, while being on TDF seems to have some form of a protective effect. So even with more data needed for children, we know that we can confidently maintain the NRTI backbone and have our clients do well. So do we need to change MBC to 3TC? No. Let's move on to Africa. The Vicent study, which other people have called the African Nadia. So they looked at 1,201 patients, divided them in two arms, Arm A and Arm B, and